It's a foreign name, but I want you to know that I grew up in Cincinnati and went to University of Cincinnati for most of my education. I'm a Bearcat, and finally we got a winning season, so I'm really thankful for that. I trained here at the University of Cincinnati, did my orthopedic surgery and general surgery training here, and I went to the Cleveland Clinic. I almost made it out of Ohio, went to the Cleveland Clinic and did my fellowship in adult reconstruction, hip and knee reconstructive surgery, as well as shoulder surgery. We've been in practice here for 25 years, first with Wellington Orthopedics, and now Wellington and OrthoCincy are now in the same practice together. So we are providing 40 to 50 doctors are now all together, coordinated, trying to provide the best care that we have in Cincinnati. And again, I'm board certified both in orthopedics as well as in sports medicine. So my practice is focused on adult reconstructive surgery. So that means we're reconstructing adults, and the joints that I specialize in are hips, knees, both total knees and partial knees, as well as shoulder surgery. One of my passions has been over the last several years trying to get robotics and computer navigation into the practice. Again, we do a lot of sports medicine as well. A lot of techniques that we can try to do cartilage preservation, meniscus surgeries, shoulder surgeries, rotator cuff repairs, etc. With COVID, the opioid epidemic, we have really tried to avoid hospitals, or even if we do surgery at a hospital, like the Joint and Spine Center, we want to make it an outpatient surgery where you go home right away. And we try to utilize minimally invasive surgery as well as robotic surgery to try to accomplish that. And we'll talk a little bit later about how to do these surgeries, these fairly painful surgeries where when I started doing joint replacements, we had patients in the hospital for 5 to 7 days. You went to a nursing home for another 3 weeks. And now it is to the point where we haven't done it yet, but you could probably stick your leg out the car window. I can do your surgery with a robot and we can drive away. It's not that close yet, but we were trying to get it to the point where within about an hour or two after the surgery, people are comfortable going home, and being able to avoid the inpatient stay. Again, at Christ Hospital and as well as the Wellington Specialty Surgery Center, we were able to do these surgeries in an outpatient and doing it in a minimally invasive way possible. So let's talk a little bit about hips and knees. We have just a few minutes, and I don't want to get into the nitty gritty of how to do the surgery for fear of somebody will try to do this in their kitchen. So I'm not going to tell you the specifics because I know a couple of engineers that will probably try this. What we want to do is just kind of give you an overview, and really, if you have questions about your personal health and stuff like that, please come in and see us, and we'll be happy to give you our best opinion of what your diagnosis is and what we can do about it. Not all hip pain or back pain or pain that you're having in your leg requires surgery. I want you to know that for sure. An evaluation by a board certified orthopedic surgeon, myself or one of my partners, is really important in trying to figure out why you're in pain and what we can do to get you better. And again, I want to emphasize all through this talk, although we're talking about surgery, I'm a board certified orthopedic surgeon, majority of the things we do not involve surgery. We try everything to try to prevent surgery. And then when we do decide, you and I both decide, or your spouse, obviously the significant other has a major contribution to this decision. When we all decide that you need surgery, what's the best way to do it? What approach should we use? Should we use robotics? Where should we do the surgery? All these decisions have to be made in a collective fashion. So let's talk a little bit about joint. So let's start about the hip joint first. So the hip joint is made out of a ball and a socket. And it is the thing that the bearing surface between the two bones is something called cartilage. We all know about cartilage. Unfortunately, when the good Lord made us, he didn't give us a whole lot of cartilage. It's very thin. It's measured in millimeters and not in feet or inches. So it's like, if you can liken it to the tread on a tire, When we wear out that tread, that's when the pain starts. We start getting the cartilage destruction, the joint space is narrowed, we get bone spurs. It's almost like a square peg in a round hole, very painful. People get basically groin pain that can radiate down to the thigh. And obviously create pain, decreased range of motion. Usually it's in the groin area, can be on the side of the hip, can be in your butt. But it really significantly affects our quality of life and our activities of daily living. So this is an X-ray of a normal hip joint on the left. On the right, you can see where there's joint space narrowing. So sometimes just a simple X-ray will tell me a lot about what kind of condition that we're dealing with. So what happens to the joint that can create this loss of cartilage? Most of the time, it is osteoarthritis, which is a fancy word for wear and tear. As we all put more and more miles on our car, the tires wear out. And similarly, our cartilage can wear out. And once it's gone, unlike other tissues like skin and bone and some other tissues, it does not heal. After the age of about 12 to 14, cartilage really does not heal. So osteoarthritis is the most common arthritis form. Inflammatory arthritis like rheumatoid arthritis, psoriatic arthritis. These are all other types of arthritis that the immune system can actually attack the joints and cause arthritis. Trauma, if you get into a car accident or fall, you can have an injury to your hip and injure the cartilage, and it can die. It's a live tissue. So if you crush it or the blood supply goes, it can cause significant damage. Speaking of blood supply, there's something called AVN or avascular necrosis, where the blood supply to the ball is gone, and secondarily, people can get arthritis from that. Infection can cause destruction of the cartilage. Certain childhood diseases like dysplasia, where the cup is not formed properly, or a growth plate injury like a slipped capital femoral epiphysis can cause it. Childhood AVN called Perthes disease can also cause it. And then we can see the destruction of the hip happening in younger and younger people. So the common modality of the joint destruction is cartilage damage, and secondary, the cartilage space decreases, bone spurs form, and people get a lot of symptoms. So again, as the common theme through this, a surgeon saying that surgery should be a last resort. We emphasize non-surgical treatment. We work with your primary care physicians to try to help you manage pain. And again, as we all have heard about the scourge of opioid epidemic, narcotic pain medication should be the absolute last resort. And in our practice, we actually don't use it. We use it only post-operatively for the first week or two. And then, we try to stay away from it. Weight loss, a third of our population is overweight. Every 1 pound you lose, the stress on your hip goes down by a factor of 2 or 3, on your knees about 4 to 5. So weight loss in every literature study in our orthopedic literature in medicine shows a significant decrease in arthritis, pain, and progression as the weight comes off. I'm a back surgery survivor ×2. I've lost 20 pounds and I feel a heck of a lot better. So I'm here to tell you it happens to all of us. Medications such as nonsteroidal anti-inflammatories, homeopathic medications such as turmeric and curcumin, glucosamine chondroitin, all these things should be tried before surgery. And we can get years of pain relief from these. Obviously, these medications, prescription medications, should be monitored by your primary care physician. They do have side effects there, so these should be monitored and prescribed by either your orthopedic surgeon or more likely your family physician or primary care physician. Injections can also be helpful, and there are various different injections, including steroid injections or cortisone injections, gel shots. They're more for the knees rather than the hips. We've tried it in the hips occasionally when people cannot have surgery. It's not FDA approved, but we use it in off-label regard for mild to moderate arthritis. Biologics, such as platelet-rich plasma or stem cells, can also be utilized. There's no good literature that shows they're absolutely foolproof or that they reconstitute cartilage, but there are some studies that show that, especially in the knee population, that the PRP can temporize arthritis, and it doesn't stop it dead in its tracks, but it can get you a little bit more pain relief. Unfortunately, the stem cells and the PRPs, insurance companies don't pay for them, so the cost can be pretty high, in the thousands of dollars. Bracing, physical therapy, and aquatic therapy are also really, really important. And I want to highlight a little bit about aquatic therapy. You know, when I wanted to lose weight, my back was killing me. And, you know, they said just walk, but I couldn't walk because my back was killing me. And then I gained weight because I was depressed. Flaming hot Cheetos was my go-to. I apologize, but like that. So a lot of calories and saturated fats, and I sat around and got depressed. One of the big things that helped me out a lot was I got in the water. I got in aquatic therapy at the Healthplex, and there's various different places around. The YMCA's offer it. The Arthritis Foundation has a great program for just moving in the water. There's styrofoam weights that you can use, and you can actually lose a lot of weight without irritating an arthritic hip or knee joint if you have access to a pool. So just a shout out to you know, we all, when we want to lose weight or keep active, running, walking, biking, these are all the activities that we choose, but every one of those activities actually puts extra pressure on our arthritic joints. So using aquatic therapy and working with a physical therapist is really an important thing that we can do. So what happens in a hip replacement? So this is all kind of, don't mean to gross anybody out, and I didn't. It's around dinner time, so I didn't want to show actual pictures of surgery being done. So if you go from you know, left, right, and down, I don't know if my cursor's working here, but this is a normal hip. This is an arthritic hip. Again, you see the lack of cartilage. So basically, in a hip replacement, what we do is we go from here to down here. And basically, a hip replacement involves a ball and a socket. And again, these hip replacements have to last 20, 30, 40 years when we put them in. So the first generation of hip replacements lasted about 10 years because the plastics that we used weren't cross-linked and weren't strong enough to withstand that. But the engineers over the course of the last few years have engineered these things in different bearing surfaces, ceramics, metals, to actually last. And when we put them in, they can last now 20, 30, 40 years if you use it right, if your weight isn't, you know, exorbitantly high, depending on what type of activities you choose to use. So basically what a hip replacement is putting a ball and socket into that arthritic joint. So we resect the ball and neck off the femur. We remount the acetabulum with a cup. We put in an artificial cup and implant a stem inside the femoral canal where the ball is attached. This ball can be ceramic, it could be metal. This can be ceramic, metal, or plastic. We've been getting away from metal on metal because of metal and metal problems that you probably all read about. And now most of the time we're using highly cross-linked polyethylene or plastic on a ceramic ball. And again, that articulation seems to be working for majority of our patients for years. And that's just the bearing surface. Now, how do we get that to fix inside there? About 90+% of the surgeons in the United States are using what's known as press fit technology, where the bone actually grows into the titanium and stabilizes that with time. In the past, we had used bone cement for people that were very osteoporotic or didn't have good bone density. And it was found that sometimes those get loose. And so most of the time, this is the type of technology. And when we do the hip replacement, this is how we do it. Now, the art is getting in and getting out without causing damage to the other soft tissues, and then talking about restrictions that we put on people. So how do you get in and get out? Well, we have to get into the hip somehow. And unfortunately, it's not right into the skin. It's shrouded in a bunch of muscles, and the muscles do different things. And we want to get in and get out with a minimal amount of damage. And over the last about 15 to 20 years, when we first started practice, when we were in training, we used to do the posterior approach. And a lot of times what will happen is we put restrictions on patients that you don't flex your hip up past 90 degrees, you can't rotate internally, you can't cross your legs, or you might pop your hip out. So about 5 to 10% of patients that had hip replacements through the posterior approach had hip dislocations, or they popped their hip out. So then we started going lateral, and this is what I did in fellowship up at Cleveland Clinic. We went lateral, and our dislocation rate was almost zero. Now, some people, there's no free lunch when you go through the lateral approach. You can do a couple of things. You can actually fix muscle tears that have existed, but you actually have to take down about a third of this muscle here that helps you kick your hip out to the side. And when we repair that for about 4 to 6 weeks, you have to make sure that repair is rock solid. So we'll put you on crutches and don't do any physical therapy for that period of time. And again, that's one of the most stable approaches. Then over the last 10 to 15 years, so this is 25 years, this is 20 years, and now over the last 15 years, we've utilized an anterior approach, a little bit more tough to do for us technically, but we've done over probably 1,000 of these anterior hips now, and this is my go-to approach. I'm very comfortable doing it. We have a special table called a HANA table that actually helps us do the surgery very reproducibly every single time. And this is a muscle sparing approach that we split through muscles without cutting anything. And this is, I think, if you Google, there's a lot of people that are advertising that, hey, listen, you do this anterior approach and you get your life back quicker, you're out of the hospital quicker, and you're playing tennis and everything within a week. Again, it's not only the approach, but we want that bone to heal to the metal. So we still kind of slow you down no matter what approach we use, but there's different hip precautions that we use for different things. So just as a summary, my go-to approach is anterior or lateral, depending on what you bring in where. If you have a big belly and you have a big, we call it pedunculus hanging down, and we can't go into the anterior aspect, we go into the lateral where there's less soft tissue. If you have muscle tears, we go through the side, so we can fix those at the same time. So again, when you come in, we'll take a look at you and see which way to go, which will get you the best way to get your life back. So if all hip replacements do great, so why do we get better? Why do we go back and learn how to do anything differently? Well, the common complications of hip replacement are joint implant malpositioning. We put it in wrong, or it drifted into a bad position. Some people fall after surgery and the implants will change in position. Improper implant sizing, instability or dislocation can happen. Leg length inequality, and we want the implant to fit very well inside your bone. We want to make sure that you get enough plastic in there to last you a lifetime. And sometimes the legs can be longer or shorter than the other, and people have a significant disability with that, and we're cognizant of that, and we want to get better. Premature wear, if you put too thin of a plastic in, or if you malalign the components, the implants can wear out. If you malalign a Michelin tire, if the guy that's putting them on doesn't front end align and balance them, it may wear out prematurely. So this is just some horrible examples of, again, what can go wrong. If you look at the cup, it's made out of titanium. This is the liner that we talked about, which is highly cross-linked polyethylene. The ball is modular. It can come off the stem, which is made of titanium. We can put a metal ball on there. We can put a ceramic ball on there. And the ball is supposed to go into the socket here. And this is an example of a dislocation that came in the office or came in the emergency room. You can't walk when you have this. The ball popped out of the socket. So how can we minimize the risk of that? I told you, depending on their approach, it can be up to 5% of patients that have it. This is an X-ray that came in the office. I did this hip. Again, we put in the hip in the correct position. The stem is in the correct position. The ball and socket, we put thicker plastic in there to make this last a little bit longer. But the right hip, if you look at it, it's almost vertical. And there's 3 screws in. So whoever, I didn't do this, and one of the surgeons in the community did this thing, every time the patient crosses her leg, she pops out. Not because she did anything wrong, but we did something wrong in malaligning that hip. And this is a board certified orthopedic surgeon. I know him, did a great job. He's very respected in the community, but we can all lose our way sometimes. And with the advent of robotics, et cetera, this is why we want to try to get better. We don't want people to suffer. We want you to get one surgery, get your life back, and get back to it. This is a horrible example of the cup actually being reamed all the way through into the socket. And that's a devastating injury. Now we have to take all that out. We have to go into the pelvis and take that out. We have to reconstruct this hip with new bone graft, cages, bone cement, et cetera. So we want to do one surgery, get it done right, and get your life back. This is an example, 5 years post-op. The cup is in malposition. You can't really see it, but the balls popped off and she sheared off. She actually broke the prosthesis because of the malaligned cup. So again, why robotics? Because we want you to have one surgery, get it done right, and have a great life. So the robots that we use are they're called MAKO. Stryker Orthopedics buys them. They're about $1 million, and both Christ Hospital as well as at the Wellington Specialty Surgery Center, we've invested in this technology, believe in it. I've done now 2,500 total joints with this. So, and we teach all over the country and the world. We just came back from Brazil and trained 20 surgeons on how to do that. We were also involved in training the first surgeons in South America in Santiago, Chile, and trained about 20 or 30 surgeons on how to do that. In all, we've trained about 500, 600 surgeons in America and South America to do this technology. So really believe in it. It makes every surgery the same, perfect every single time. Unfortunately, when you come in to see me, everybody's anatomy is a little different. So this is all CT-based technology. It involves a robotic arm, a stand with a high-definition camera, as well as a workstation. It is based on CT scans. So we CT scan your hip or your knee. We actually generate a 3-dimensional model of that. And actually, we were able to put in the correct implants sizing-wise and position-wise, and we can change this thing around. We actually do the surgery about a week or 2 before your surgery in preparation. So this is called pre-op planning. We'll put the cup in, we'll change the position around. The newest technology is that we can actually measure your lumbar spine angles and see how mobile or tight you are, and actually do a virtual range of motion modeling. So we can predict where the hip will dislocate before we do the surgery, make changes on the implant before we get there, and know that you're not going to dislocate ahead of time. So we're using technology and predictive analytics to try to figure out where patients are stable, where they're unstable. A lot of people that have hip arthritis also have back arthritis. People have multiple back surgeries, fusions, and this really does affect where the hip is most stable. So with this technology, we know more and cut less. So this is the virtual range of motion exercise. Again, we put the sit to stand X-ray values, is called the sacral angles in, and you can see on this virtual image exactly where this patient is going to dislocate, where they're red, the pelvis and the femur come together, and it hits right there. So we're able to, this is before surgery, we're able to change the neck length, put a little longer ball on there so they can't dislocate. Now, if we do that, your leg may be a little bit longer. So then we have to make a choice in surgery. Do we focus on leg length, or do we focus on dislocation? So those are all judgment calls that we have to make in surgery. So I want to play a little video, if I can, here about MAKO technology. So this is the robot. It's actually, we call him R2D2. He's really nice. He doesn't talk back to me like my children. My wife may be listening, so I'm not going to say anything bad about her. So we do a pre-op CT scan. We generate a three-dimensional image from that. And then during surgery, like we talked about, before surgery, I can manipulate the image around and see exactly what fits everybody. We can change sizes, so it's very patient-specific planning. During surgery, then we take that plan and we try to execute it. So it's computer-aided design manufacture. We then correlate in surgery where the patient's bone is as compared to the CT scan. We can then precisely map out how much bone we're going to resect. Then the stem goes in. We know exactly what size to put in before we even get there. And then during surgery, we can actually check and see where the implants is as compared to our size. Then we focus on the cup, again, mapping out exactly within a millimeter of a degree exactly where that cup is. We position the cup exactly where we preoperatively planned. The robotic arm then comes in. And again, I want you to understand that the robot's not doing the surgery. I'm doing the surgery. So the robot arm just holds everything in place, and I pull the trigger, and I'm able to execute exactly what I planned. So you can see the green there is exactly how much. I'm going to back this up a little bit. So it tells me exactly how much bone to resect as per my plan, and it won't let me cut any more than I've planned to. And then thereafter, I can put in the cup, the acetabular component, exactly where I want, and it tells me exactly where it is that that cup is going as to my plan. So again, we preoperatively plan, patient-specific, exactly to what is required, and then we put the implants in, and then afterwards we're able to check leg length, offset, make sure that the stability is there, or actually remove your hip around and make sure that it doesn't dislocate. We check the leg length as compared to the opposite side. Again, we may have to do some fine-tuning adjustments. If you're dislocating, I may have to make you a little bit longer on this side versus the other, just so you don't pop your hip out. Or if the hip tension, the muscles aren't tensed properly, we may be able to do that. But again, very efficient. A standard total hip replacement versus a robotic, we may add about 5 to 10 minutes, but that 5 to 10 minutes I think is very worth it, because I want you to have one surgery, get it done right, and get back to life. Switch a little bit and talk about knee arthritis. Again, non-surgical options such as injections, weight loss, aquatic therapy are all our mainstays, and we're going to do that as much as we can. We saw a lot of patients today. I think 90% were non-surgical, and less than 10% that came in the office today were surgical. And it kind of varies day by day, but really that's where we want to focus mostly. But if you've done everything, other surgeons have done surgery and injections, we're not going to repeat those, but we want to try everything before surgery. If you have end stage arthritis, we go to either partial or total knee replacement. But if you have mild arthritis and meniscus tears or focal cartilage defects or some other structural problem that we can help with arthroscopic surgery, that's a large part of my practice. And again, it depends on what exactly is going on with a patient's knee. So if you have a small piece of cartilage that's missing, we can treat that arthroscopically. Or if you have meniscus tears, we can treat that arthroscopically. If you have ACL tears, we can treat that arthroscopically. And then we take, what part of your knee is damaged? Is it the inner aspect? Is it the outer aspect? Is it just your kneecap? Is it two compartments of the three? And we can tailor make with this robotic platform now. We can actually map out exactly what the damage is and replace just that part. We can just replace the inner aspect, the outer aspect. We can do just a kneecap replacement, or we can do a combined with this technology. Just to give you an idea, in 15 years of practice, before I got the robot, I did 5 partial knees. We've done almost 550 partial knees now with this technology over the last probably 7 or 8 years. So again, this tool in our toolbox has really helped us tailor make exactly what the patients need to get their life back. And again, I want you to understand it's least invasive to most invasive. And the most invasive is really the knee, the total knee, which really, we'll go over this in a second, but it really involves that last stage where there's bone-on-bone arthritis in at least 2 out of 3 compartments, or you have some sort of arthritis that affects the entire joint, like gouty arthritis, rheumatoid arthritis, osteoarthritis, post-traumatic arthritis, some of the same things we talked about in the hip. This is, again, a pre-op planning, CT scan first, and then with that CT scan, we can preoperatively plan exactly where to put the implant, make sure that it lines the femoral or the femoral component, the tibial component are in the right spot. We can actually move things virtually around so that we get the implant loaded correctly. Again, if you put it in wrong, it won't last as long, and it'll wear asymmetrically, we call it. It won't wear correctly. And so we do all this work ahead of time just to make sure that everything's in the right spot. These are x-rays of a partial inner aspect or medial uni, a partial uni, the outer aspect of the knee. Again, if you look at how much cartilage space is left in these other knees, it looks pretty good. That's why we didn't do a total knee. But if this patient had a 2-compartment or bicomp knee, again, a very young patient that did not want to have the total knee, we preserved her ACL, PCL, collateral ligaments, etc. Some people don't want anything to do with this and want to go straight to a total knee replacement, and that's completely okay. I'm not a dictator except for my children. We want to, make sure that patients are very much involved in their decision making. And again, this is not cancer. This is not a heart attack. You guys really are who are going to help us both make the decision. The ultimate decision is yours. And a total knee replacement basically involved resurfacing all 3 compartments of the knee. So again, knee replacement has been around for 40 years. Most people do really well, but if you really ask people, there's about 20% of them that are really dissatisfied. In my whole life, I've been trying to understand and help people that are dissatisfied with their knee and make sure that if I do a knee replacement, I try to do everything in my power to try to prevent that. The biggest problems we have in knee replacement and implant surgery in general is infection. Infection can ruin a hip replacement, knee replacement, anything we do. Infection is our big problem. One of the things we do help with robotics and instability and malalignment. If your implants aren't aligned properly or the ligaments aren't balanced properly, knees don't work right and can be very problematic. So my goal is to reduce our revision rate or make sure that the knee is aligned well and balanced well so that we don't have any complications. And again, we utilize this MAKO total knee software and hardware to be able to do that. Again, the whole idea here is no more before you go into surgery. So CT based, we know the center of rotation of your hip, your ankle. We realign you with respect to your mechanical axis. If you're bow-legged, we try to make you straight. If you're knock-kneed, we try to make you straight as well. If you have big bone spurs, we can take those all out. We know what sizes are available or what sizes the patient is before we even go in. We know where to put that implant. We know where there's a landmark called a transepicondylar axis. We know that on a CT scan, and really it's guesswork when we're doing it in a manual fashion with the manual techniques before the robotics. We know where to put the implant. We know how many millimeters of bone to resect to restore your anatomy. We can try different sizes before we even get there to make sure that this is absolutely the right custom designed implant for you. And then during surgery, this is a live in-surgery picture we've taken. We can balance your knee so that the ligaments are all balanced, and it's something called a flexion extension gap is balanced within millimeters, and we can make these fine-tuning adjustments in surgery. And then once we make those fine-tuning adjustments, we haven't cut any bone, we haven't done anything yet, So once we make that, then it becomes a computer-aided design manufacturer. So the robotic arm comes in. Again, I'm doing the surgery. Robot just helps me execute the plan within a millimeter degree. The other thing that happens is the robotic arm, if I've registered your bone and it lets me only cut within a millimeter degree exactly what I pre-programmed to do, it will stop my blade if I try to color outside the lines. So super accurate, super safe to help protect soft tissues and reduce the complication rate and execute my plan to a millimeter degree. So what does that help us do? Well, it helps decrease our soft tissue damage because the blade doesn't go outside where I'm cut. In documented literature, in our textbooks, it shows that we have about 30% less pain. We have now gone from, I was telling you, 3 days in the hospital. Now it's outpatient. The length of stay in the hospital has decreased significantly. So at Christ and at the Wellington Specialty Surgery Room, we're doing a lot of these people. Probably 75% of patients are going outpatient. There's less need for inpatient physical therapy stays, and overall, again, less overall pain when we do these. And initially, it was anecdotal. My patients would come back and say, "Doc, especially the ones that I did, a regular knee on one side and a robot knee on the other side." They were telling me that this feels better, this works better. What happened, and it's really this technology to be able to do the surgery perfectly every single time. So pain control has, I'm rounding. I'm not going to tell you how old I am, but there may be a 6 involved in it and a 0. So I'm going to get there one day, I think, and I want to make sure that the guy that does my surgery makes sure that he does everything as good as possible, and that's really what we want to offer you guys. So we use robotics. That cuts down about 30% pain. We've stopped using tourniquets on our legs. That cuts down significantly more pain. We use cold therapy after surgery that really helps with decreasing overall pain. We use a multimodal opioid sparing cocktail medicines that help really decrease pain. And then this newer medication, which we were the first in the tri-state to use. We've used more of this stuff than most surgeons in the country. It's called ZenRelief. It's a long-acting local anesthetic with an anti-inflammatory built in that lasts for 3 days. And I've operated on a lot of people. About 300 have had ZenRelief, and these people are telling me that by far most, there may be some people that have some increased pain, but the ZenRelief patients probably 60-70% less pain. There's several people that I know have not taken one pain pill after surgery. Again, everybody's different, but we're doing everything we can to try to decrease pain, to try to get the surgery done perfectly every single time, to reduce complications, get you guys out, and get your life back. I was telling Dan, who's sitting right next to me here, we just got back from a trip to out west in Zion and Bryce and Grand Canyon with my kids. And, I was down in the hoodoos down in Bryce, and I looked over. I told my wife, if I couldn't do this, I'd be really, really irritated. So in the next 10, 15 years when I retire, I really want my mobility. I want to go out west. I want to, we were talking about Sprinter vans and stuff like that. That's the kind of life that we want to lead, and we want to restore our function. We want to enjoy life. The last 2 to 3 years has taught us anything. Life is precious, and time is the essence. So, let's get up, get walking, and anything we can do to help you guys out, let us know. And time is the most important thing. So on that note, we'll end this. Let me go over to some questions here. So let's go to first question. In addition to better results, does robotic surgery decrease recovery time? The answer is, in my experience, yes. What you come into surgery is really what you get out. So if you've been suffering for 10 years, your range of motion is, barely 60 degrees. You barely can walk. I've got people coming in here on a wheelchair. I don't care who does your surgery, robotically or non-robotically. We're going to do the surgery perfectly. The implants are going to be put in right. Their alignment's pretty great. The range of motion is pretty great. But recovery really involves a lot of different things. It involves range of motion. It involves strength. It involves endurance. It involves proprioception or muscle retraining. And we've really found what you bring to the table really defines how quickly you recover. So if you've got great range of motion, good strength, good endurance, you're playing pickleball 3 times a week, and you're walking a mile a day, those people really bounce back quickly, and the robotic surgery does great. But if you are somebody that is barely walking, has trouble getting to the bathroom, robotic surgery will make your recovery better, but you really have to do a lot of physical therapy before and after surgery. And the people that do surgery, that do prehab before surgery, bounce back a lot quicker. So what you bring to the table really defines how you will do afterwards. Is there expected time range for how long a joint replacement will last? Again, in a lab. So these companies have these machines called Instron machines. They're stressing these knees and hip replacements out. And I've visited them. They're in New Jersey. They're in Warsaw, Indiana. These things, they're engineers that are specifically trained, and some of these are FDA requirements, right? They have to see how long they'll last. They're putting 5 million cycles at 160, 170 pounds, and they're lasting 20, 30, 40 years. But if the test conditions change, if that 150 pounds suddenly becomes 250 pounds or 300 pounds, and if you're trying to run marathons or do a lot more activity, if you go from 5 million steps to 10 million steps, it really depends on, that will define how long the surgery, how long the implant will really last. Maybe one of the other questions, so what is the timeline from decision to have surgery to actually having the surgery? So the timeline really involves, again, a lot of variables. My surgery schedule is booking out probably 8 weeks or so, 6 to 8 weeks, depending on the time of the year, those types of things. My availability in the operating, or the availability, there's so many different surgeons that are down at Christ Hospital that we only have 1 or 2 days that we have quote unquote block time. So that's a rate limiting step. We do about 8 to 10 surgeries a day. That's the other thing about robots. They don't get tired. Surgeons get tired. So the 10th surgery has to be as good as the first surgery. Otherwise, we should limit how many we do so that surgery becomes perfect every single time, even if you do 10 a day. So the decision making is, again, whenever you decide to have surgery, we put you through your paces. I'm a big proponent of decreasing complication rates. So we actually put you through your paces. We look at who you are. We look at things like body mass index. If you're over 40, your body mass index is over 40, your chance of getting a complication is significantly higher. So that preoperative time frame we utilize to optimize all the risk factors that we can to decrease your risk. We look at your A1C for diabetics. If your A1C is over 7, you're going to have a significantly higher infection rate. So we delay surgery until we get that number down. Smoking has shown significantly to increase your complication rate. In spine surgery, we've known for 30 years that spinal fusions and spinal surgery have much higher complication rate and don't work in smokers. So we ask for 6 weeks before and 6 weeks after to stop smoking. So if you come in and decide to have surgery, we look at you and optimize whatever risk factors we have, and then basically put you on the schedule. We also look at cardiac issues. If you've got stents placed or you have open heart surgery, we utilize your primary care physician, your cardiology network, to make sure that we have the surgery done safely. Cardiac patients, we take the Christ Hospital. They have one of the foremost premier cardiac programs in the country, and really want to utilize that for anybody that has a comorbidity of coronary artery disease and has had heart surgery in the past. One additional question, how can I prepare for surgery? I think we've covered that. Again, prehab involves an organized physical therapy, a visit where you go to our physical therapist. They'll put you through your paces. They'll do some measurements on your range of motion, your strength, and they'll actually do exercises with you in a safe fashion and give you a home exercise program. Aquatic therapy, along with the Arthritis Foundation exercise program, can really help loss of weight, increasing your nutritional baseline in that taking a lot of multivitamins. Vitamin D especially has been shown to help us heal. There's been a lot of studies, especially with COVID now, people that had low vitamin D were getting sicker. People with diabetes were getting sicker. People with higher BMIs were getting sicker. So if you think about what COVID has taught us, who gets sick? Those are the same people that have complications after surgery. So if we can prepare for surgery by decreasing our overall risk and optimizing those conditions, that's really what we're after. We want you to get through the surgery and not have any complication whatsoever. So is arthritis hereditary? Not usually, but there are a subgroup of patients that I've seen. There's one family here in Cincinnati that I think I've seen pretty much everybody. I've seen grandma, great grandma, I've seen mom, I've seen several uncles, and I'm actually now on the fourth or fifth generation. And I can tell you, and those poor individuals are getting arthritis probably a decade or two sooner than I would imagine. Some form of rheumatoid arthritis can be also hereditary. This follow-up question, if so, what can I do to prolong the onset? Really, the number one thing in prevention of arthritis is weight control. Weight control is number one. Every study that we have in our literature shows that weight loss can prolong your native joints and prevent joint replacement surgery. Next question was, how long does a knee replacement last? And again, I think we've covered that. I'm active and I want to run still. Want you to run. My wife's a runner. She's ran Boston. She's ran Flying Pig, Chicago, and Columbus. She's actually, I'm really proud of her. For the last 10 years, she'd organized the Forest Hills 5K run here in Cincinnati. We have 2,500 people run that every year. Actually, one of my partner's wives took that over this year, and they had a great outcome. So I love running. I want to be active. I can't run anymore because my spine surgeon told me that I would herniate my disc for a third time. So, and she can't run much anymore because everything hurts. So we've now, this is how triathlons were invented, I think. Now we swim and we bike, so we cross train a little bit and decrease the overall run. If you've got active arthritis in your knee and you're still pounding on it, this is a great way to come meet us in our office and get knee surgery. But after knee surgery, we really don't push the running aspect of things because I tell people you can run if you're late for an airplane or chased by a bear. I want you to run fastest than the slowest person in your group. I don't want you to be that person, but I want you to run for exercise because that'll wear out the knee a little quicker. Again, remember that machine that cycles your knee back and forth. Imagine pounding on that knee. That knee will wear out. That artificial knee will wear out a little quicker. Do I use robotic assisted surgery for every knee replacement? I'm happy and embarrassed to say yes. I won't do a knee replacement without the robot. I think it's that good. I've done it now routinely for 7 to 8 years. I cannot remember the last time I did not use a robotic arm. Actually, I do remember there was a workman's compensation patient that the CT scan was not paid for. And for that one patient, we used the next best technology, which was computer navigation. Still use advanced technology to put it in. I don't want anything to do anything bad to anybody. I want to use the best and latest technology. I want you to get your life back and get back to normal activities. So the answer is yes. I use it in pretty much every knee replacement surgery. Next question. Can someone expect to get back to normal activities after hip replacement? Define normal, and I'll tell you what that is. Normal is different for, activities of daily living, walking, taking care of yourself and others. Really, the hip replacement is done for two reasons. One is for pain and one is for function. Pain is reproducibly relieved. That bone-on-bone pain is gone. After any joint replacement, I'm going to tell you, you're going to have some pain. In knee replacements, we can normally get that pain from an 8 to 10 out of 10 pain down to about a 2 or 3. In hip replacements, is usually better, but some people still have residual pain. A lot of people have pain in their back that can be causing pain. People have, spinal stenosis. People have SI joint dysfunction. When you drive a car, if you drive a car for 60,000 miles, you can tell me that your left front tire is the only thing worn off on it. I'm going to tell you, probably look at your right rear tire, is probably worn about the same. So other things can happen. I've one unfortunate, one of the nicest guys you ever want to meet came to me needing 2 shoulder replacements, 2 hip replacements, and 2 knee replacements. So the question is can I get back to normal activities? Well, he couldn't, because he needed all 6 of his joints replaced before he could get back to normal activity. So again, normal activities of daily living, taking a walk. A lot of my patients are playing golf. They're playing doubles tennis. If you could ski before, you will probably dial it down 1. If you're a black diamond skier, I'll ask you to dial blue. If you're a blue skier, light blues and greens. If you're a novice skier, I would say don't ski anymore. I don't want you to fall and break anything. Again, better results, and does robotic surgery decrease recovery time? I think we've went over that. Time range for how long a joint should last, again, depends on how you use it. Again, 20, 40, 60 years. Decision for surgery, I think we covered that one. So age limit, too young, too old? Great question. I don't know the answer to that question. I asked my financial advisor when I first started, how much money do I need to make to retire? And he said, that's an easy question to answer. Just tell me when you're going to die, and I'll tell you exactly if you're too, how much money you're going to need. So I'm going to answer the question the same way. Are you too old? Just tell me we're going to die, and I'll tell you if you're too old. I look at comorbidities. How's the rest of you? Is your heart good? Are your lungs good? Is your body good? You're not diabetic. I can't predict how long you're going to live. If your chronological age is in the 80s, but your physiologic age is in the 60s, and you're going to last till you're 105, because there's some people that are lasting that long. I don't want you to suffer 25 years. Let's get your joint replaced when you're healthy and get back to surgery. Get back to life. This is a great question. Generally speaking, do insurance companies cover the robotic surgery? So the answer is most do, some don't, and if they don't, we write off the cost of the surgery, or not the robotic portion of the surgery. The CT scan, which is required for surgery, sometimes is, sometimes isn't. We've got prices down now with most of the hospital systems and ProScan Imaging, Christ Hospital, to about $200 to $300 for the CT scan. So not insignificant, but not a make or break. And I think that the money spent, the money is well spent on getting that done, so we can have that 3-dimensional model. So am I the only one using MAKO for knees? No, some of my partners are also using it. Dr. Wiggins, Dr. Hummel, Dr. Hummel and I are probably the highest volume guys in the city. I've trained pretty much everybody. If some of the people that I've trained, it's like religion. Some people, are very used to doing things in a certain fashion. They get good results, and that's the way they've always done it. But I'm in teaching mode pretty much 24/7. I teach 5 residents every year. My graduation's next week. These poor guys have been in training for 20 some years, and they're finally graduating. So each one of them has been certified on how to use the MAKO. Again, it's really the commitment of the hospital and the surgeon. The hospital, Christ Hospital, has made a commitment to provide excellence for joint replacement surgery, and they have 2 robots. That's how committed these guys are. As part of my commitment to Christ Hospital, we've trained most of the surgeons that want to be trained in robotics in Cincinnati, and they can utilize it at Christ Hospital. Are there fewer muscles cut during robotic knee surgery? The answer is most of the time we don't cut any muscles during knee surgery. We cut either through a tendon or to the side of the muscle. The beauty of robotic surgery for knee replacement is that the soft tissue envelope around the knee, there's hard stops. The robot won't let us cut outside those hard stops, so less soft tissue damage. One of the big ligaments inside the knee, called the posterior cruciate ligament, is protected by software, so it won't let me physically. I will try to push that blade as hard as I can. It won't let me. It'll dead stop. It'll stop the blade. So the muscles during traditional and robotic surgery are about the same, but it's that soft tissue envelope, less damage, quicker rehabilitation, and exact positioning of those implants like the manufacturer wanted us to do. So that was the last question. Now you guys get to enjoy dinner or an after dinner drink. And I really want to tell you thank you for your time. And I also want to thank our sponsor, Christ Hospital, as well as OrthoCincy for allowing us to spend this time together. And also Dan Wiggins, who is quietly standing by and put this thing together for me. So I've got spots on my face, so I apologize for that. The sun is setting over our day today. So thank you for your time, and have a great day. Thank you.